Bismillah ar-Rahman ar-Rahim. Welcome in this very rich meeting of Egyptian Society of Nephrology and Transplantation, continuous CME meetings, online meetings. Today we are honored to have two major professors as a moderator and as speakers. Our moderator today is Professor Mohsen Al-Kousi, consultant of renal physician in United Kingdom, and Professor Mohsen was with us as a speaker in a past session, which was moderated by our great Professor Rashad Barsoum. If you heard the introduction of Professor Rashad Barsoum, you can Professor Mohsen in this session. Before you can know who is Professor Mohsen well, and who how was he is working in Egypt, and after he was transferred to UK. We are honored today to have Professor Mohsen as our moderator, and Professor Amr Elhussieni as our speaker in his area of interest and the specialty of CKD PMD, speaking about the parathyroid story. Before I leave the floor to Professor Mohsen to lead the meeting and introduce Professor Amr, I would like to welcome all our attendees today and all our attending professors. And I expect to have a very rich, interesting session and a very rich scientific discussion we are waiting for. Thank you all, and please, Professor Mohsen, start.
Thank you very much, Professor Yasser, and good evening for everyone. And thank you very much for these nice words. It is my pleasure as well, and it's my honor to mention the name, just enough to mention the name of Professor Amr Elhussieni. I don't think that I need to mention anything else. He is well recognized for not only nationally, but internationally. Probably the only thing that I would like to mention, not his scientific merits as a professor of medicine, director of renal medicine in the University of Kentucky, but obviously about his values and principles. He's a very good character. He's a sincere and honest friend. I like him that much, and I'm sure that everyone in the floor knows him better maybe than me. We will learn from him today in his area of expertise, and we will enjoy it, I'm sure, from that. Professor Amr.
Thank you so much, Dr. Mohsen. Thank you so much, Dr. Yasser. I'm really humble and happy that I'm with you today. One of my greatest time I spend with you guys, because we share ideas, we learn from each other, and hopefully we are trying to improve our patient care and improve our patient quality of life and survivors. Today I'm going to talk about basics that we are dealing with every day. We are going to talk about this amazing parathyroid gland. I just want to leave you, if I need just to leave you with one single message, is how amazing this gland is, how it functions day and night. It's a blessing and a mercy that we have such organs that micromanage and nano-manage our life, and with any single deviation or abbreviation in the function, in the quantity or the quality of these organs or glands, our life changed dramatically. And I will try to convince you how important this gland is in the next hour or so. Of course, one of the major advantage of this meeting is we remember Dr. Shaisha's legacy, how he contributed to the scientific community, not only in Egypt, but in the Middle East, in Arab countries, and the whole entire world. سنكتب ما قدموا وآثارهم. سبحان الله, آثار Dr. Hussein Shaisha still present, and we hope that he is getting hasanat, inshallah, for whatever we are doing, because he initiated this, he created this, established this program many years ago, and we are following his footsteps. So I'm trying to take you on the journey to try to see what is the structure, the anatomy, the function, the physiology of the parathyroid gland, its role in mineral homeostasis, and we'll talk a little bit about complexity of the BTH measurement. Then we'll talk about parathyroid disorders. And to start with this, impressive, remarkable glands, it's unique and distinguished in every single feature. And if you just try to imagine or ask yourself how many times we have 4 copies of any organ in our body, and I don't think we have many of those. We have either single organ like the heart or double organ like the kidneys and the lungs, but very, very seldom to have 4 glands, superior, inferior, right and left. Not only that, if you go to the embryology, these glands develop from different pharyngeal pouches. Actually, the superior gland develops from the 4th pharyngeal pouch. So the superior comes from inferior pharyngeal pouch, and the inferior comes from superior pharyngeal pouch. So it's particular, unique, and distinguished in every single feature. The other thing is, if you know, the kidney matures and develops usually by week 12 or 13. Most of our major organ develop, after the 10 to 11, 12 weeks when it comes to heart, to lungs, and to liver. But this parathyroid gland develop very early in our life, develops and mature usually at week 6 to week 8, fully mature by usually week 8 of gestation. And this tells us something, because our major organs cannot function without the presence of mature parathyroid glands, because all the metabolic activities in our cells, all our organs, especially the central and the peripheral nervous system, the skeletal system, the cardiovascular system, cannot function without the parathyroid gland, cannot function without very tight control of the extracellular calcium concentration. You remember, we need calcium for all metabolic activities, the all intercellular activities, and all organ function. So parathyroid gland tightly control the serum calcium concentration. So the gland develops very early in our life. If you look to also the anatomy of this gland, it's embedded underneath the thyroid gland. And when I look to this picture, I usually think that the thyroid gland looks like a shield that protects the soldier who is a fighter and who's trying to protect his village or country. So the parathyroid gland is a very strong soldier that works day and night to protect us, and it's covered by the thyroid tissue. When it comes to the endocrine system and to the major glands we have in our body, as you can see, we have several endocrine organs, but only 3 of them we cannot function. We cannot live without these glands for more than a couple minutes. Of course, the adrenal gland that secretes the metanephrine, the cortisol, the pancreas that controls the blood sugar, through the secretion of insulin and glucagon, and the parathyroid gland. These cells, these glands, if we take them off, we cannot, and if we, of course, we don't replace their function, we die within minutes. The other gland, we can live without it for days, for weeks, or months, or maybe indefinitely when it comes to, especially to the ovary and testicle and the reproductive system. But other glands like pituitary glands, thymus glands, and even thyroid glands, we can live without it for weeks. But when it comes to parathyroid gland, this is not the case. The other particular thing about the parathyroid gland, whatever specialty you do, it's not only in medicine, but also if you are a dentist, you're going to deal with the parathyroid gland disorder, either hypo or hyperparathyroid disorder. If you are a surgeon, if you are a urologist, if you are orthopedic surgeon, internal medicine, nephrology, endocrine, rheumatology, all specialties, you have to understand the basic physiology and the function of this gland, because it's pivotal, it's very, very essential for our life. We try to understand how many parathyroid molecules comes out from the parathyroid gland on daily basis. We give this assignment, we give this task to one of our PhD students. It took for her weeks to come up with calculation how many parathyroid hormone we form and excrete to the peripheral circulation. It depends on the average serum concentration, the molecular weight, and the half-life of the parathyroid hormone, which is very short half-life. By the way, the half-life of the parathyroid hormone is only a few minutes, maybe 5, at large, not more than 10 minutes. So this means that every 10 minutes, 5 to 10 minutes, we renovate, we recycle all of our parathyroid hormone. This means that this gland is working day and night to maintain the Bth secretion and excretion, because in 5-10 minutes, all the Bth we have is gone. We have a brand new, completely new Bth every 5 to 10 minutes. Depending on this calculation, we come up with this. Our parathyroid gland secrete about 1.3 quadrillion. This was my first time to know the quadrillion. I know there is millions, billions, trillions, but first time to know this quadrillions, which is a million of billion, whatever. So it secretes huge amount in the blood. The other thing is not all the parathyroid molecule that is synthesized or formed by the parathyroid gland goes to the peripheral circulation. Actually, if you have low serum calcium concentration, only 60% of the pro-Bth that is formed inside the cell will go to the peripheral blood, and about 40% of that will be degraded. This is in case of low calcium CO, so we need more Bth. If we have higher calcium, actually the Bth secretion is suppressed. So about 80% of the Bth that is newly formed inside the gland is going to be auto-degraded. So this gland is not only working as manufacturer to form Bth, but also it has also a sewage or disposal function that it auto-degrade and destroy the new Bth that the body doesn't need it. Why it secretes more if the body doesn't need it? Because we don't have the luxury to be in need for more Bth and it's not there. So just in case, if our body in the next couple minutes will need Bth, it's there. And I will show you how this will happen, but it cannot wait to form new Bth that can take a couple minutes if there is not enough in the blood. The relationship between the extracellular calcium concentration between the ionized calcium and the Bth is very, very tight. You see this curve, you see this setup point. So when the serum calcium concentration goes down from 1.1 to 1, just 0.1 difference. See what will happen with the Bth. 100% more secretion of the Bth just with this very small fraction, 1 decimal, decrease of the extracellular ionized calcium concentration. On the other hand, if the level goes up from 1.1, say to 1.2, there is 50% reduction of the Bth secretion. So small changes in the serum calcium concentration have a dramatic effect on the Bth level. And the set-up point illustrates the sensitivity of the parathyroid gland toward the ionized calcium concentration and extracellular calcium concentration. So in normal circumstances, and the homeostasis that we are every day, every minute, our parathyroid gland is dealing with is there is several phases of Bth secretion. So if we need more Bth, there is, this is a parathyroid cell. So this parathyroid cells, it have inside it vesicles that contain parathyroid and brew Bth. When we need more, if the calcium goes down or if there is a trigger, the calcium sensor or the calcium sensing receptor feels like we need more calcium because our calcium is going down. What will happen? These vesicles will move from inside to outside, will be closer to the cell wall. Then when it touches the cell wall by a process called exocytosis, the inside Bth molecules will go directly straight to the blood. This process takes seconds. Very robust, very swift, very quick and rapid release of parathyroid hormone doesn't take a fraction of seconds to be released to maintain the same extracellular calcium concentration. And with time, if this doesn't help, or if the stimulus persists, so we need more and more, then there will be a signal toward increased Bth formation, synthesis, and secretion through the signal that will be sent to inside the nucleus to increase the Bth mRNA and increase Bth gene transcription and gene expression. If is this not enough, this usually takes hours to happen. If this is not enough, with time, there will be a parathyroid hyperplasia. So the number of parathyroid cells will increase. So first, the function will increase. Second, there will be increase in gene transcription. Then third, that takes usually days, there will be increase not only in the secretory function, but also in the number. So this manufacturer will start to form newer cells, and these cells will be hyperactive. So there will be a cellular proliferation and secondary hyperbaria that will maintain the serum calcium concentration. If you want to dig deeper and see how this happened, and this is just an amazing phenomena, it's just one thing that happened in our body. And if you look to our body, how the crosstalk happen all the time, how the signal works together, how the cells communicate with each other, how organs, send signals and up-regulate and down-regulate the molecules and hormone. It's amazing relationship. And this is going on and on 24/7 in our body, and we don't even feel it. We don't even notice that these manufacturers are working. They are not noisy. They work quiet and nicely to keep us alive and to keep our function, within the normal range. So here is the calcium ions. If we have low calcium ions, what will happen? If this happens, there will be a stimulus to the calcium sensory receptor. This calcium sensory receptor, we got to know about it a couple decades ago. Before that, no one knows how the calcium tightly control the Bth and how the Bth, secretion and stimulation happen. But a couple decades ago, they discovered this amazing calcium sensory receptor. And if you see, it has three parts. One is extracellular part, extracellular domain, this part. Then there will be a parathyroid intramembranous part, so inside the parathyroid cell membrane, so it's called transmembrane or parathyroid cell membrane part, and it's 7 helicals. It's very, interesting structure. Then inside the cell also there is intercellular part of this calcium sensing receptors. So if there is enough calcium, this calcium sensing receptor will shut down the Bth secretion, will shut down because it sends signal to inside the nucleus to decrease the gene transcription. And if it senses that the calcium is low, it will activate the Bth secretion. Of course, as we talked about, the vesicles that is going to mobilize from inside the cell to outside the cell and will commit suicide called exocytosis to release these Bth molecules. If you see what will happen, here is very small glands. There are 4. Each one is the size of very, very small. This is like a rice size. And of this rice size parathyroid gland, there is millions of cells and there is millions of parathyroid receptor. Here is the receptor. You see, this is the extracellular part. This is the transmembrane part, and there is inside the cell part of this. It senses a calcium. Once it senses a calcium, it shuts down the Bth secretion. Here is the parathyroid cell, and it stops the parathyroid gland secretion if there is enough calcium. And of course, as we know, that the parathyroid gland will go first straight to the bone. So if the calcium is low, if we need more calcium, it will release, it will increase the bone resorption. It will go to the kidney, where also there is calcium sensing receptor and the vitamin D receptors in the kidney to stimulate the urinary calcium absorption. And of course, it will activate the vitamin D to increase calcium absorption through the gut. So there are, interrelated. They have crosstalks with several other organs to maintain our serum calcium concentration within normal. What happened in our CKD patient? Why does Bth go up in our CKD patient? This was just a very brief introduction about the calcium homeostasis and Bth. But what happened in our patient when the kidney function goes down? There was what we called trade-off hypothesis. And in the past, we used, our professor used to teach us, and we used to teach our students that when the kidney function goes down, with nephron loss, the phosphorus is retained, so there is no enough excretory capacity to release the phosphorus load. And also there is inactivation, or there is no enough 1-hydroxylase enzyme to activate the 25 to 125 dihydroxycholecalciferol, and both will induce relative hypocalcemia, and this will stimulate the Bth secretion. And initially, there will be a down regulation of calcium sensing receptor and vitamin D receptor. This is called the old trade-off hypothesis. This is not valid anymore. What is the new? And actually, it's not very new because it has been there for almost 12 years now, that the new trade-off hypothesis is not related to the phosphate retention or to the hypocalcemia, because both are late findings in the course of our CKD progression, but the initial finding will be increased FGF23 secretion. FGF23 will keep the phosphorus within normal range. This is the reason that we don't see hyperphosphatemia early on in our CKD, because it's a phosphatory hormone, but this will happen on expense of deactivation or decreased activation of 25 to 125 dihydroxycholecalciferol. And when the vitamin D is less active, the Bth, of course, will be more active, and severe downregulation of vitamin D receptor, calcium sensing receptor, not only those, but also FGF23 receptor and clotho will happen. So in the past, we used to say that we have a negative close feedback between the parathyroid gland and the kidney, because parathyroid gland secretes the BTH. BTH stimulates vitamin D. Vitamin D inhibits BTH. So this is called close negative feedback, because if the BTH stimulate, for example, vitamin D, then the vitamin D further stimulate BTH. This will be a vicious circle. One will activate the other, and it will be a vicious circle. But we have what we call closed negative feedback. So one hormone will stimulate another hormone, and this second hormone will inhibit the first. So this is a controlled environment. Now we have at least what we know is 3 negative feedback mechanism, closed loop, one between the bone and the kidney, one between the kidney and parathyroid, and the other between the parathyroid and the bone. And the bone is a very important co-player here because it secretes the FGF23. So FGF23 is a phosphatoretic hormone that comes out mainly from the osteocytes and to a lesser extent from osteoblasts. And as we mentioned, FGF23 will inhibit everything else, will inhibit vitamin D, will inhibit BTH secretion, and vitamin D will stimulate BTH, and BTH will deactivate vitamin D, and BTH will stimulate FGF23 while FGF23 will deactivate BTH. So 3 negative close feedback loops that are working in our body all the time. What happened, and this is the normal curve that is going to be shifted to the right side in our patient with CKD. So this means that you need higher level of serum calcium concentration to inhibit the BTH secretion. And in severe cases of tertiary hyperbaria, of course, you can find the combination of moderate to mild hypercalcemia in presence of also the hyperparathyroidism. So I think we talked a little bit about the structure, the physiology, the anatomy, how the gland function, what is the role of parathyroid gland in mineral homeostasis. And let us shift gears a little bit and talk about BTH itself. How can we assess and examine and evaluate and assay the BTH in our blood? Then we can move to the parathyroid gland disorder later on. I'm sorry to be very basic this time, but to understand exactly what happens in disease, we have to understand what happens first in health. We have to understand physiology to understand the pathology. So do we really understand what is the BTH? To be honest, maybe 10, 20 years ago, I used to teach, and I used to also learn, but in the last decade or two, my understanding, and I'm still learning about the BTH every day with my friends, with my colleagues and students as well. We read and we try to dig more and more and understand more and more. But let us challenge our knowledge and understanding of the BTH. What's the BTH? We are talking every day about BTH. What is this BTH? BTH is this amazing molecule. If you dig more, if you dig deeper, you see this is an 84 amino acid molecule, and it's not only one structure. So there is N-terminal that starts here with the first couple amino acids, which are usually the most important calcemic amino acids, the biologically active. These first amino acid will dictate the biological activity of the parathyroid molecule. While this is the C-terminal, and the C-terminal, the carboxy terminal, and the amino acid terminal is N-terminal. So carboxy terminal doesn't have a say in the hypercalcemic effect of the BTH. Actually, there is experimental evidence that it might antagonize, the C-terminal might antagonize the calcemic effect of the N-terminal. So it's a little bit complicated here. So we have one structure with two biological functions. The first amino acid dictates the hypercalcemic effect, and maybe the C-terminal, which is usually 34 to 84 molecule, might antagonize this, at least experimentally. We don't have very good evidence clinically. We'll come back to that. So if we are talking about assay, we are going, Diego will tell you we have to, check your patient's BTH every 3 to 4 months and to keep the BTH between 2 to 9 folds of the upper limit of normal. So you have to understand what we are assaying. So the first BTH assay was discovered it's about 60 years ago, okay? And this was basically this person, the scientist, he created a polyclonal antibody against the carboxy terminal epitope of the BTH molecule, okay? So here is the N-terminal, and here is the first amino acids, the first 5, 6, whatever, 7 amino acids that dictates the hypercalcemic function of the parathyroid. So it doesn't really target that. It doesn't really target the whole N-terminal, but it goes and target the C-terminal part, which is, we don't really know or understand exactly what its function, at least clinically, okay? Then, of course, this was innovation, because even before that, the surgery to do parathyroidectomy for renal patient with severe hyperparathyroidism used to do this since 1920s, 1930s, even before discovery of the BTH assay. So they know that these patients have very bad bone disease, they have the fractures, they have very bad high turnover bone disease, what we call it osteolysis fibrosa cystica. So they have brown tumor, and they found that this is controlled by this parathyroid gland. So, they did surgeries, they took out some of the gland with or without autotransplantation, and it works, even before discovery. So they discovered the first assay in 1960s. Here is the evolution, what happened over time since in the last 50, 60 years. So we start with a polyclonal. Of course, polyclonal is non-specific. It can attach here to the BTH, but also it can attach to different other molecules. So it's not very precise, not very accurate. The other problem with this, it attached to the C-terminal, not only the C-terminal, but to the last amino acids that is usually have negligible effect on the parathyroid function. This was a radioimmunoassay. Then they moved from 1960s to 1970s. As you see, they moved toward the central or the proximal part of the C-terminal. Then in 1980s, they moved from the C to the N-terminal. So there was a big move in 1980s that we start to understand better that the N-terminal has most of biological activity. So they moved to the N-terminal and left the C-terminal. But this was all, discovery happened by radioimmunoassay. In 1990s, they changed the assay to more precise assay, what we call sandwich ELISA by second generation immune metric assay. And what happened is they used 2 antibodies, one called capturing antibodies that captures the C-terminal, and one called detecting antibody. So this is why we call it sandwich ELISA. So one is targeted to the N-terminal, one is targeting the C-terminal. Then, about 15 years ago, they moved from the terminal part to the proximal 1 to 5 first amino acid. And this is the 3rd generation immune metric assay. So if you ask me, what assay do you use in your lab? I have an answer for myself. But if I ask you the same question, do you have an answer? You should have an answer. Are you using 2nd generation immune metric assay or 3rd generation immune metric assay? Are you detecting mainly the intact BTH or other? I will show you the impact of this, and I want to get your attention for a couple minutes because it's very, very important. Here is what we call IBTH. We are talking all the time about intact. What's intact? What's the word intact? Where did it come from? We have to understand this basic concept. Otherwise, we are not going to handle and grasp the idea of the Bth assay and its importance in our patient. This is the whole molecule, right? The 184. You remember, it's 84 amino acids. So what happened when the cell, the parathyroid cell, secrete and form the parathyroid molecule? It can come out as a whole molecule. It can go to the circulation and stay as a whole molecule. But this is not the case in all cases. So some of the Bth comes as 184. Some will be N-truncated like this one. There is no N-terminal, it's all C-terminal, 37 to 84. So this might be missing the hypercalcemic effect of Bth, or it might be missing the first amino acid, the first 6 amino acids. So this one is 7 to 84, and it might be only part of the C-terminal. Very few, if any, will be the biologically active N-terminal. But the majority, if we want my opinion on this, will be either the whole molecule or the C-terminal, either the 3784 or the 3484, and I'll show you this in a second. The problem is more complicated in CKD patient. Why? Because this 784 is retained. It's a bigger molecule. The molecular weight is higher. So it's retained in patients with kidney disease, with advanced kidney disease, and especially in dialysis patients. So the fraction or the ratio of 184 to 784 will be less. What does this mean? Okay, if you have a patient with a Bth of 1,000, okay, this means that maybe this will be 50-50. 50%, which is 500 of the Bth, will be the biologically active, the whole 184 Bth, while the other 50% will be biologically inactive. So say this, this patient will have a Bth, which is biologically active about 500 picogram per ml. Okay, other patient who will have this 3 patient, all of them have the same Bth number. When you send them for assay, with a second generation ELISA, they will come with the same number, say just 1,000 to make it easy. This patient will have only 200 of biologically active and 800 of biologically inactive. And this patient has the opposite. This patient have, very good ratio of the 184 to 784 Bth. What does this mean? This means that this one will have much higher chance of having high turnover bone disease, because of the percentage of the ratio of the biologically active, the 184, over the biologically inactive, the 784, is much higher. So this guy has more biologically active Bth, has more a chance of having high turnover bone disease, despite he has the same Bth concentration as this patient B, and this patient B probably can have less chance of having high turnover bone disease compared to patient A, which has 50-50 chance. Okay, to make it more complicated, and I'm very sorry, but this is the truth. We have to understand this concept before dealing with an abstract or absolute Bth number, and we're saying this Bth is 300 or 400 or 500, you have to understand what is that. Because if you use different kits, for example, in our lab, we use diazorin. Diazorin gives you the lowest, it's very precise test, and it gives you the lowest numbers. Even the reference range is very low compared to other, like if you use Beckman or Roche or Siemens, especially Siemens Emulite will give you. So if you send this a blood sample, you take it from the same patient and divide it to 2 parts and do the Bth assay using diazorin, it might be 50 or 60, but if you send the rest of the blood sample and do it in another lab, with using a semen immunolyte, they give you another completely different value, maybe up to 170, 180. So there is 3 to 4 fold differences in the BTH assay, even using the same blood sample. So basically, we have to understand what methods you are using, and you have to be consistent if you are sending your patients. Don't switch between labs. Don't switch and change between kits, because different labs, they have different values, different reference numbers, and they give you different assays. We published this article 3 years ago, and basically we try to make it more simple. Here is the first generation that we used, using the only one antibody toward the C-terminal, and then they move this to this double antibody, one to the central portion of the N-terminal and one to the C-terminal. Then the third generation is just using the first few amino acid in the N-terminal plus the capturing antibody toward the C-terminal. And if you are more interested to learn about it, you can read this article. It's very basic. Here, basically, the advantage, the pros and cons for each of the first and second and third generation ELISA. And actually, in our division, we came in, not me, but even before I joined them, they came in with this, very smart idea. If we are talking about the second and third generation of the radioimmune assay, and the whole molecule, biologically active or biologically inactive, they said, why not to make it a ratio and divide the 184, the biological active, over the C BTH, which is the 784. Anyway, so you can, if you are using first generation in 2022, that's obsolete. This is not acceptable. At least you probably, most of the BTH assay in Egypt is as a second radioimmune assay, the second generation ELISA. It's mostly widely used. Now we are trying to move to the third generation. However, all the KDIGO guidelines are still based on studies that was done using the second generation ELISA. The third generation is better. It's more precise, more accurate. It gives you less number compared to the second generation, but again, it's more expensive. It's less widely used and not adopted by the KDIGO guidelines. Of course, if you want to be more precise, you can do the 184 over the 784, and it will not give you only one parameter and neglect the other, but the ratio is important to differentiate or discriminate between high turnover and low turnover bone disease. This is a very important background, and I know that all of us as clinicians, we hate the physiology. I hope that I make it easy and straightforward and helpful to understand what is coming next, which is the parathyroid gland disorders. Dr. Mohsen and Dr. Yasser, let me know if you want me to keep going. I can keep going a little bit, or if you want me to stop here and to open the floor more about the calcium sensing receptor and disorders, the clinically relevant calcium sensing disorders, which is usually they are 7, but to make it easier clinically, I would just say hypoparathyroid disorders, hyperparathyroid disorder, and familial hypocalciolic hypercalcemic disorder, FHH. So hypopara, I'm not going to focus. We know that as nephrologists, sometimes we see patients with hypopara, most commonly after parathyroidectomy. So hypopara is less common than hyperpara. We know the manifestation of hypocalcemia, which is clinically relevant, but if you don't have these symptoms, you can induce it by, we have different tests. You can tap in front or, on top of the facial nerve in front of the external auditory meatus, and you see the twitches that will happen or the spasms that can happen if you increase the, cough pressure. But basically, most of the manifestation of hypocalcemia or hypopara is all about neuromuscular excitability. Causes, it's very common, especially in CKD, after hypoparathyroidism, after the parathyroidectomy. Of course, there is congenital and familial causes. We are not going to talk about it. Pseudo-hypopara, which is usually there is enough BTH, but the receptor there is resistance at the receptor level. So instead of having good BTH, in the blood, it doesn't work. And I'm not going to talk about it. It's called the hereditary Albright osteodystrophy. So there is several resistance at the receptor level, not only to the BTH, but also to the thyroid and to the further stimulating hormone, luteinizing hormone. It's associated with absent or short fourth and fifth metacarpal. There is actually the phenotype picture without really abnormality of the BTH. Okay, so if you have hypoparathyroidism, there is two options. You can increase the calcium, you can increase the calcium supplement and calcium intake and vitamin D intake, or you can try either to use the hormonal replacement, which is not, there is no consensus about long-term hormonal replacement therapy in this patient, or you can use calcilytics, which were not approved by FDA because they failed the RCT, big studies. By the way, I hear patient, people are talking about doing either allo or maybe auto transplantation of the parathyroid tissue after extensive parathyroid surgeries and inducing hypopara after parathyroidectomy. There is still, there is no big study. It's all about case reports, especially with allotransplantation. Auto, if you expect this patient might develop hypopara after extensive thyroid surgery or parathyroid surgery or neck irradiation, you can preserve some of the parathyroid cells, then you can auto-transplant it. In allo, the problem with allotransplant, you have to give immunosuppressive medication. It can be more doable if the patient is getting renal transplantation or other solid organ transplantation, and he will be on immunosuppressive medication anyway. In this study, this patient, he got allo transplantation. It was solitary without other organ transplantation, and he was maintained on steroid only for a month, and they followed him up for more than 6 months. And it was a curative for this patient. Again, it's case report, it's not a standard therapy. What's FHH? Familial hypocalciuric hypercalcemia. It's autosomal dominant disorder characterized by inactivating mutation of calcium sensing. So when we give calcium mimetic, you activate the calcium sensing receptor to shut down the secretion of parathyroid hormone. This is opposite. This is autosomal dominant disorder in the calcium sensing receptor. So this receptor is not functioning. It's inactive. Okay, so there will be hypercalcemia, but the gland cannot see it. So there will be a continuous parathyroid gland stimulation and function because this sensor is not working properly. It's associated with long-standing, mild asymptomatic hypercalcemia. It's not injurious. You have to live with it. Don't do any of the problem with it. It's usually you can mistake this as hyperpara, then you do an unnecessary surgery, then the patient, problem is not going to resolve after the surgery. So usually the BTH is mildly elevated, despite that the serum calcium is mildly elevated. And the take-home message is do urinary calcium excretion or calcium creatinine ratio, 24-hour urinary calcium, whatever you want to do. So the 24-hour urinary calcium excretion will be less than 100 in these patients, so they are hypocalciuric, and this is the reason that they are hypercalcemic. It's more common in children and adolescents, and the major thing is the low urinary calcium and the magnesium excretion, and the major challenge is to distinguish this disorder from mild hyperparathyroidism. By the way, the first case of hyperparathyroid bone disease was discovered in Egypt, in Dakhla, in Wahat al-Dakhla, the Dakhla oasis in Egypt in Roman Empire time, and they found a mummy with severe ostitis fibrosa cystica and hyperparathyroid bone disease. They did bone histomorphometry. So again, Egypt again is making the history. So it might be primary or secondary or tertiary. What's primary hyperbaria? Very important and common disorder. One of the most common endocrine disorders. I think it comes out after the diabetes, the type 2 diabetes, and the hypothyroidism. It comes as the primary hyperbaria. And it's usually asymptomatic and associated with mild hypercalcemia. And usually the calcium doesn't move, takes years for the calcium to go higher and higher. So if you have a patient with a calcium of 10 this month, then 11 or 12 next month, or 13 or 14 after 4 or 6 months, this is not primary hyperbaria. Primary hyperbaria, you see the patient with a calcium of 10.5, and in 6 months from now, it might be 10.7 or 10.8, and in a year or two, it might be 11. Very insidious, very slowly, chronic insidious disorder. And it's usually because of a single adenoma in one of the 4 parathyroid gland in 80% of patients. It could be a primary hyperplasia, either diffuse or nodular primary hyperplasia in only 15 patients. And in this patient, you have to try to exclude either men 1 or men 2A and B. In men 1 and men 2A, they have parathyroid hyperplasia, both of them. In men 1, the 3B is pituitary, parathyroid, and pancreatic tumor, as you know. In men 2, parathyroid will be there with medullary thyroid carcinoma and fuchrocytoma. In men 2B, there is no parathyroid disorder. It's only medullary thyroid carcinoma, fuchrocytoma, and it's usually associated with skin manifestation and skeletal manifestation, morphonoid habitus, and mucosal neuromas. And parathyroid carcinoma is very rare, less than 5%. And by the way, in 5% of the adenoma, it can be multiple in several parathyroid glands. So the primary hyperbaria is a disease of adults, especially in women, and usually discovered routinely. Usually it's asymptomatic or have very mild symptoms of hypercalcemia, which is usually stable and mild. And here, the manifestation of primary hyperbaria, mainly the bone manifestation, which is basically the high turnover bone disease with ostitis fibrosa cystica, osteoporosis, fracture, bone loss, bone pains. In the kidney, several things can happen. Basically, it will induce nephrogenic DI, nephrogenic diabetes insipidus, so the patient will have polyuria, which can initiate dehydration. And dehydration can also augment the hypercalcemia a little bit, not very common in primary hyperbaria, but in other hypercalcemic disorder. And it takes years for nephrocalcinosis or kidney stones to happen. And in GIs, you can present with several things: peptic ulcer, gallstones, pancreatitis. So this patient can be also dehydrated because they don't eat well, because of the peptic ulcer or gallstone or pancreatitis, and they can develop also chronic depression. So we call it painful bones, renal stones, abdominal groans, and psychic moan. This is a manifestation of chronic hypercalcemia. This is very important how to distinguish if you have a hyperparathyroid disease. How can you distinguish between other reasons of hypercalcememia and different BTH levels? So this is the primary hyperbaria. So there is mild increase. See the calcium usually less than 12, rarely to reach 13, just in few, but the majority is between 10 to 12. Okay, and the BTH is usually elevated. So the word elevated here is tricky because if you consider increased BTH level of more than 60 or 70. Here, anything more than 20 in presence of hypercalcemia is elevated BTH. So you have to be careful. So if you have a calcium level of 12 or 13, the BTH should be suppressed, should be less than 20. So if you find a BTH of 30 or 40 in presence of moderate or severe hypercalcemia, that's abnormal, okay? So you don't have to wait to a level of 60 or 70. Here is the hypercalcemia of malignancy. What will happen is you see the calcium level might be very high and acute and change it dramatically within weeks or months. It can be moderate to severe in many circumstances, up to more than 13, which is moderate, then more than 15, 16, up to 17, okay? Hypoparathyroid, these are the patients who are hypoparathyroid. The calcium is low, the BTH is low. But the tricky part is this, the FHH is the familial hypocalciolic hypercalcemia. They can overlap with the primary hyperbaria because there is mild elevation of the BTH because they have inactivating mutation of the calcium sensitive receptor. So they would have mild hypercalcemia and also mild elevation of BTH. So if you have a patient with hypercalcemia, the first step is to verify that he is really hypercalcemic, recheck the corrected calcium or ionize the calcium. If it is true hypercalcemia, you do your clinical judgment, clinical evaluation, then measure the intact. The first thing you need to do is to measure the intact BTH to see if it is BTH related or BTH unrelated. So, and we said the cutoff level of 20 picogram per ml is very important. So if it is higher than that, this means it's BTH related. And it's either primary hyperbaria or FHH. And we talked about how to distinguish through the urinary calcium. So check BTH, check urinary calcium. If the urinary calcium is low and the BTH is mildly elevated, it might be the FHH, which is autosomal dominant disease. If the BTH is suppressed, so that's appropriate suppression because of the hypercalcemia, this is not a BTH related, it might be BTH-RB related, which is secondary to malignancy, so the BTH related peptides, or it could be either because of 25 or 125 dihydroxycholecalciferol elevations. This means that either the patient is taking vitamin D that can elevate the 25, or calcitriol or alpha calcidol that can increase the 125, or the patient have lymphoma or thyroid or sarcoid disease that can increase extrarenal stimulation and activation of the 25 to 125 dihydroxycholecalciferol through the granuloma that secrete the 1-hydroxylase enzyme. Other things, it's myeloma, or hypervitaminosis D, or hyperthyroidism. All these will increase the serum calcium concentration with suppressed BTH, with not measured BTH-RB, and normal or low 25 and 125 dihydroxycholecalciferol levels. We do evaluation of the parathyroid tissue either by ultrasound or by systemic scan, different ways to do that, or CT of the chest, not to judge that the patient needs surgery or not. So if the patient needs surgery, there is certain indication, I'm going to talk about it, but it's just as a preoperative assessment, mainly to exclude presence of ectopic parathyroid tissue in the mediastinum or outside its anatomical, distribution in the lower part of the neck. The image, there is variability in accuracy and precision between different, radiology department and machine. And the image is significantly less accurate, less precise in multiglandular disease. It's more accurate and easy to detect if there is only single nodule or adenoma in one of the glands in the neck. It's harder if it is in the mediastinum, or it's it's ectopic, or there is multiple glandular disease. Here is the indication to do parathyroidectomy according to the 2014 guidelines for surgery for asymptomatic primary hyperbaria. So in the past, they used to say the serum calcium more than 1, bone loss, so DEXA scans, there is osteoporosis, evidence of osteoporosis. Renal, the GFR is less than 60, and nothing mentioned about the 24-hour urine calcium. Now, see the weight of the kidney. There is the added more and more to the kidney as indication for the surgery. So as the GFR is going down to less than 60, if there is kidney stones by CT or X-ray or whatever ultrasound, or you do the urinary calcium, if it is more than 400 milligram per day, so you do 24-hour urine calcium, or if there is other, indicator of stone formation like hypoparathyroidism or hyperoxaluria or hyperuricuriuria or any other increased chance of forming stones, especially in younger population, if the patient is less than 50, because it's insidious, it's chronic disease. So these younger people in 10 or 20 years, they will lose more and more of their bone, and also they will have higher chance of losing more of their kidney function, so they need intervention. Of course, you can also use cinacalcet, or the calcium mimetic in this patient. It can lower down the serum calcium, it can lower down the BTH. However, it can also improve a little bit the BMD by DEXA scan. However, its impact on fracture and long-term, solid outcome, not only surrogate marker, is still controversial. Let's just talk in a couple of minutes, and I'm going to stop. I'll give you a brief introduction about why secondary hyperbaria happen, mainly in our CKD patient, but it can happen also in our CKD patient and in general population because of vitamin D deficiency or calcium deficiency. So this can be combination. So even in patient with CKD, especially in early CKD, if you see elevated BTH, it could be just representative of vitamin D deficiency or a manifestation of calcium deficiency. So maybe the patient is not getting enough calcium, doesn't have good sun exposure, or the patient has GI losses because of different reasons, or rarely there is some renal leak. So there is increased calcium loss because idiopathic hypercalciuria or use of loop diuretic. And you can see the hyperbaria is not very early sign in patient with CKD. It's a late sign. Actually, it doesn't happen till CKD stage 3B, at least with GFR of less than 45. See, this 45 still, they maintain almost normal BTH. But the early sign is just the decrease 25 vitamin D level and 125 dihydroxycholecalciferol level that can happen even with GFR about 75. So in CKD stage 2, they start to have less active form of vitamin D, and this, of course, will take time to stimulate the BTH secretion. Why do we need to control the BTH in our CKD patient and calcium and phosphorus and these mineral homeostasis? Because it's very well-known risk factor for bone loss and renal osteodystrophy and osteoporosis, not only because that, but it also will put the patient on the highest cardiovascular risk. Our patients dies usually because of cardiovascular calcification. So the CKD, FVD is not only renal osteodystrophy or biochemical abnormalities of hyperphosphatemia or hypocalcemia or high BTH or FGF23, but also include the increased cardiovascular calcification. As we know that there is dramatic increase in our patient mortality compared to general population, whatever the age, the race, the gender, they have, our 20-year-old dialysis patients, they have 500-fold higher rate and risk of mortality compared to matched general population. So it's very important. Almost the 25-year-old dialysis patient have the same mortality of 85 60-year-old person in general population. Why they die? There are several studies that showed the CKD-MBD, the abnormality in mineral homeostasis, they put them on the highest risk of mortality compared to anemia, hypertension, inadequate dialysis, and other risk factors, which are very well recognized risk factor for increased morbidity and mortality. Of course, this happened because of the intimal calcification, the medial calcification that can happen in our patient. In non-CKD patient, the calcification happened inside the lumen. It happened due to atheroma, that plaque formation that can rupture and fracture, then calcify inside the lumen. But here, the lumen is patent. It's wide open. If you do a coronary cath, for example, you can see the lumen is wide open. But see, the media is thicker and it's less elastic. It's less compliant. It doesn't accommodate for increased demand. So if you need if there is increased demand of blood supply, you increase the flow. You do vasodilation of the blood vessel. Vasodilation cannot happen here because of the stiff artery, the very rigid wall of the muscular layer, the extra cellular muscle layer is just calcified. So here you see this all calcification that kills the elasticity and the compliance of the artery. And of course, you see the density of the blood vessels that the coronary arteries has the same density of the bone. Okay, I think that's enough for today. We can talk about hypoparathyroid and hyperparathyroid disorders later on, and I will leave it up to the discussion section because I think I talked too much, and let's give more time to the participants, the audience, and the guests and the organizer to discuss further clinical points. I'm so sorry to be very comprehensive and detailed, but I think to understand the clinical portion, we have to understand the basic science behind it. Otherwise, we'll be in the middle of nowhere. And thank you so much.
Thank you very much, Professor Amr. As always the case, not as usual, it's as always the case, very fascinating. You have dissected a very complex area that I believe that every nephrologist is suffering when he's just dealing with it. I believe that we will go for, we need obviously our area of interest, the CKD and BD, further about the secondary hyperparathyroidism, but it seems that you have now exhausted and probably also the floor as well. But I'm sure that there are plenty of questions that we might be able to take now before I can ask my question. So please, if someone has got a question.
Okay, please type your questions in the chat. We have one question now.
Okay. Patient after parathyroidectomy and BTH of 4 picogram per ml, take active vitamin D or not? Serum calcium 7, take oral calcium or only? Can I repeat? I believe that you have got an.
No, I have it. I have it. I just give time for everybody to grasp that question. Again, very, to be honest, every single meeting, I talk about the, parathyroid gland and CKD-MBD. I have the same dilemma, post-parathyroidectomy, hypoparathyroidism, post-parathyroidectomy, adynamic bone disease, post-parathyroidectomy, hypocalcemia, how we manage it, how we treat it. And the thing is, we don't have magic. The problem is to prevent it, basically. Why this patient end up with a BTH that was probably total with or without, even if you implant parathyroid tissue, it didn't function, it didn't work well. And this patient ended up with a BTH of 1 digit, a single digit, 4, which is basically you're killing his bone. You remember, you need bone resorption to stimulate bone formation. And bone resorption is the first stage for bone formation. You start to resorb bone to form bone. So if you don't have BTH, you're not going to resorb bone. If you need more calcium, 99% of your calcium stays in the bone. you lose your reservoir. You don't have calcium in the bone. So if you need more calcium, you lost your chance, and you don't have parathyroid gland. So the parathyroid gland is not going to help you to, the same mechanisms that we mentioned to keep the normal calcium homeostasis. The take-home message that I want to leave you with, that the parathyroid tissue is very, very important. Okay, it's like your heart, your liver, your kidney. It's a major organ, and it's very, very bad, irrational to keep the patient without parathyroid tissue. This is not a cancer. You don't have to do radical treatment. You don't have to take the whole parathyroid gland and to keep the patient without any parathyroid tissue. Especially, can I add more? And I can talk to on this till tomorrow. The problem happened, patients start with severe high turnover bone disease. Probably this patient, you didn't give us the Nasma, I think Nasma Suleiman, who is asking, and thank you for her question. She didn't give us what happened before the surgery. Probably this patient has a BTH of, say, 2,000, right? Severe high turnover bone disease, severe osteitis fibrosis cystic. So we are changing the spectrum, instead of having severe high turnover bone disease, now we end up on the other end of very low turnover bone disease or adynamic bone disease. What happened is, and I tell you this, this is just a concept. I want to prove it or disprove it, and I tell you exactly how I'm going to do this. Aluminum intoxication is common in Egypt, period, okay? We did just a couple of bone biopsies. This year, one is this year, one last year, okay? And, they have aluminum in their bone, okay? And this, I'm here in Egypt. I arrived in Egypt yesterday, and I'm planning to do closely to 12 to 14 bone biopsies in Mansoura in this visit, mainly to rule out or to rule in the aluminum intoxication, which for me, and it was a surprise in our bone histomorphometry lab, because I take this specimen and we analyze it in our bone lab, and they didn't see a single case for 30 years till I brought them our specimen. So it's not shameful. We have just to focus. We have to understand what's going on. It's not only about high or low turnover bone disease. We understand that low BTH increased chance of aluminum intoxication, period, okay? If you have more active bone, it decreases aluminum staining, it decreases the retention of aluminum in the bone. If you have hypoactive, acellular, dead bone, it increases the chance of accumulating more and more aluminum in the bone, and this will kill the bone more and more.
Professor Hisham, sorry. Professor Hisham, I believe, has got a question, but he is muted.
No, yes, I was just muted, not to disturbing you. Thank you very much, Professor Dr. Amr. It is a really amazing gland and a magnificent as well talk. If you allow me just to say that you perfectly explain why dialysis did not improve and will not improve and will not be a major treatment for patients with hyperparathyroidism, although it is a dialyzable protein or peptide, because it's a very dynamic gland. So the dialysis calcium will affect more the serum PTH, although in some literature, parathyroid hormone are removed during dialysis and could be found. Now, I think that we can explain later how what's in the bone comes into flesh. So we have the calcification, calcific arteriopathy, despite bone disease. So it's typically what in the bone come into the flesh. I have just to say one question for you, if you allow me that. You described that in patients with CKD, there is much more medial calcification. Although the endothelial phenotype changes into a bone and intravascular calcification is well known to be found in CKD. So why patients may be more towards medial calcification like hypertension and other disorders. And this could be explained in calcific chromic arthropathy and organ damage in patients with CKD and patients on dialysis.
Can you repeat your question, Professor Hisham, please?
I grasp the question.
Yes.
I can explain it. Thank you so much, Professor Hisham. We always learn from you. Yes, of course, you can remove the BTH partially by dialysis, but again, it's very short acting. In 5-10 minutes, whatever you removed, it will be back. I mean, the gland is very active, and in normal homeostasis, it takes 5-10 years. And patient was secondary or tertiary hyperbaria, it might be a minute or less. So it's not a modality to control hyperbaria. That's number one. The calcification part, yeah, I agree completely. So in CKD patients, they have both traditional and non-traditional risk factor. Of course, they share the same traditional risk factor as non-CKD patients with increased atherosclerosis, because majority of them are diabetic, hypertensive, have endothelial dysfunction, obesity, inflammatory mediators, smoking, sedentary life, it's going on and on because they share the same traditional risk factor. But the non-traditional risk factor on top, the general population or the diabetics are not hypercalcemic or hyperphosphatemic, or they don't have high BTH. There is inducer. Of course, there is balance between the inducer and the inhibitor of calcification. In CKD patient, for some reason or another, there is increased, mediators and stimulator of vascular calcification that also is interrelated to the bone. So the calcification doesn't only happen, or mineralization doesn't only happen in the bone, but happen in the skeletal and extraskeletal in the blood vessel. So it's interrelated. So first, they have increased mediator and decreased suppressors of calcification. I think we will have next week, Dr. Elbaz is going to teach us about calcification, and the suppressors and inducer of calcification, especially post-transplantation. But again, this is peculiar for CKD patient, that the vascular smooth muscle cells actively and inactively, first calcification happens because of, if you both even ex vivo calcium and phosphorus and BTH, they are going to precipitate, right? But also in human, it's not only inactive process of calcification or mineralization, but it's active because the vascular smooth muscle cells, it changes its structure and function to be an osteoblast-like cells, start by itself to secrete mediators of calcification, even without having surplus of calcium or phosphorus or high BTH or higher FGF23 or low clotho and this and that. It will by itself actively induce an environment for increased calcium.
Calcium microparticles, yes, and it's a balance between promoter and inhibitor in such a way. If you allow this just to the floor, because it's some debatable. When you recommend to give Prolia, denosumab, for patients with CKD or on dialysis, I understand that in normal calcium and etc. But sometimes there is giving denosumab for such a patient.
I expect there will be a separate session for CKD, secondary hyperparathyroid and on dialysis, but
right.
No, even in CKD, yes.
Right. I can briefly answer Dr. Hisham. Yeah, but because I didn't talk, in details about the therapeutic, pharmacological, and non-pharmacological intervention, we'll keep this in details for the next time, inshallah. But just briefly, yes, you can. The problem with denosumab, it's it's a monoclonal antibody against RANKL ligand, and this is one of the promoter of osteoporosis, because the RANKL actually stimulate all steps of osteoclastogenesis, so it increases bone resorption. So it's basically an anti-resorptive therapy. So it's helpful in patients with non-CKD, mainly for osteoporosis, but also there has been several studies, small and larger studies that showed efficacy. However, safety, the problem with CKD patients, there was several reports and warning about inducing severe hypocalcemia in CKD patients, in dialysis patients. We have to be careful. Because, again, it might be a good indicator, because if you stop the osteoporosis, if you stop this hungry phagocytic cells, which are the osteoclasts that used to remove calcium from the bone, and now you induce more bone formation. So you start to mobilize the calcium from the blood to the bone. This is actually a good sign. This means you are building bone, you have less bone resorption. Then you have just to deal with the consequences of hypocalcemia that was mentioned in many of the literature. But it's a good medicine. You can give just one injection, every sub-Q injection every 6 months. And it's a smarter medicine because the other alternative is bisphosphonates. We can talk
it's obsolete,
about bisphosphonates
we are
forever.
not prescribing, yes.
Right, but bisphosphonates, there is other concerns that they are retained. So if you want to give it in CKD or dialysis patient, you have to give, smaller dose or increased frequency, the duration between treatments or something like that. But again, the bisphosphonates just kill the osteoclast, and it can kill it indefinitely because bisphosphonates stay in the bone for 6-7 years in general population. For CKD patient, it can stay in their bone forever, indefinitely.
For life.
Induce adynamic bone disease. It can induce a typical femur fracture and so on. So this is a smarter way because the rank L is not indefinite thing. You can just down-regulate with using a smarter medicine. Like
I believe we have a question. I believe we have got a question from Professor Tariq Elbaz. I'm not sure whether he is still has got the question or.
Yes, I still have it. First of all, thank you so much, Professor Amr. It was such an intensified dose of science, pure science. I really enjoyed what you said tonight. I'm going to ask questions. And let me start by the first one, which is related to vascular calcification. Naturally, you just pick up where you left, and would like to ask you a question of all the pro-calcific factors and all the traditional and non-traditional risk factors. What's in your opinion the most difficult to tackle? I mean, most of them more or less we can do something about. What's in your opinion the most difficult to tackle? And it is of significant influence, of course.
Yeah, I'm not very sure that I got the question. You're asking about what is the most important factor in calcification?
Your voice, Professor Tariq, is somewhat away. Your voice is somewhat away.
The pro-calcific factors, is my voice okay now?
Little bit, yeah. What is the most important pro-calcific factor?
Yes.
No, not the most important, the most difficult to
tackle?
to treat.
This is the most difficult question to answer too.
I have a vision and I just want to see your opinion.
No, I want to learn from you, sir. I know that you are studying this now.
No, absolutely. It's an open question.
I can tell you the easiest ways, okay? I'm not quite sure about the hardest way to tackle. I'm a humble guy. I can tell you simple thing to tackle, okay? If this is okay with you.
Simple way. How about inflammation? This is my view. I mean,
inflammation is there, but the inflammatory status is not only unique and peculiar to dialysis patients. They are there for others. The other thing is, if you control the inflammatory status, I'm not very sure we have solid evidence that this is going to decrease the calcification. I'm very sure that you know this better than me. There might be some up-to-date literature review that you already came across during your preparing your
No,
lecture.
absolutely. It's just one factor among all the others.
Right.
I just look to inflammation or inflammaging, let me say, as something really difficult to deal with. It's multifactorial in its on its own. Supposing that you can fix the matrix graph protein, you can fix the FETWIN, the FGF23 and PTH and so forth, still inflammation will be still there and difficult to tackle. That's how I see things. Well, okay, let's skip this question and take you back to the parathyroid. After your very complex display of the PTH assays, we know for a very long time that we are not really able to measure PTH. How far are we from reality? As you said, here in Egypt, and I was surprised, by the way, to hear about aluminum intoxication still being here in Egypt. This is a very, very important point. And please, in our future meeting, we would like you to enlarge more and more about this, because we just had the thought that it's over, but it seems that it is not. Maybe we are not biopsying patients, and that's why. So my question, how far are we from reality if we are not able to accurately assess the
Very good, very good. Okay, thank you so much, Dr. Elbaz.
How far are...
Yes, I got you. Three things, three comments. I'm going to briefly try to highlight it. First of all, the calcification is very, very debatable. If inflammation, of course, inflammation can contribute, but to treat the calcification with anti-inflammatory medication, by the way, bisphosphonates, some investigator, they are convinced that one of the benefit of using bisphosphonates in CKD patient and in other hyperparathyroid bone disease is because it also has some anti-inflammatory properties, and also even especially after transplantation, it has some immunological. I mean, there was some studies that showed patients who received bisphosphonates, their rejection was less, their kidney function after transplantation was less, the markers for inflammatory markers was better. Anyway, if I'm convinced or not, still there is just few small studies that show that. We need, of course, bigger RCTs to conclude. This is number one. Number two, aluminum intoxication. Yes, I was surprised. I thought we already, passed this stage 20 years ago with the newer water treatment, utilities and the RO devices we have. I was surprised. I was shocked. The first biopsy I have done, and we found this, and second biopsy, we found that. Again, we need, I think it's very premature, very early, but if we see this, and this time, in this at least 12 biopsies we are planning to do next week, it will be another national warning that we need to talk about. By the way, bone biopsy, and with your help and others, we have Dr. Hisham Said, Dr. Yasser, Dr. Faisal Shaheen from Saudi. We need to establish bone biopsy consortium, and we need to do more bone biopsies to see exactly what's going on in our patient. We cannot judge based on couple or 10 or 20. We have to get more bone specimen to have better understanding. The last thing about where are we from BTH assay. My take-home message is BTH by itself is not magic, okay? BTH give you, or let me rephrase that. If the BTH is very low, 2 digits or 1 digit, less than say 100, 99 or less, or more than 600 or 700, that's easy to discriminate hypoparathyroid from hyperparathyroid disorders. The problem happened with BTH of 150 to 600 or 500. The bone turnover can be all over the place. with the same patient with a BTH of 300 or 400 can have, and if you see this slide, I didn't talk about it, but just for instance, it can explain a little bit what will happen. So if a patient here in the middle have a BTH 150 to 300, you see 2/3 of them, they had low turnover bone disease, and 1/3 have high turnover bone disease. If the BTH is more than 300, still 1/3 of them or more, they have high turnover bone disease. So the chances of low and high turnover bone disease, you know, it changes with the BTH number. But if you have BTH within the normal range, say 200, 300, 400, very, very hard to discriminate low from high. The tricks are, and I'm going to tell you briefly without going in details, otherwise we're not going to finish the discussion. Don't only depend on the BTH, depend on other markers. One of the most useful markers is the total alkaline phosphatase. Very feasible, doable, and a little bit precise, not as precise as the bone-specific alkaline phosphatase. If you can get that, that is a good bone formation marker. But if you can't, I think we all do liver function, and part of the liver function we get total alkaline phosphatase. If you see this parity between the BTH, so if the BTH is say 500, but the alkaline phosphatase is low, so I think twice this might not be high turnover disease, or the opposite. Okay, if they goes in the same direction, so alkaline phosphatase is too high, BTH is moderate or high, this means that this patient have higher chance of having high turnover bone disease. So I can treat this with confidence as a high turnover, and vice versa. Okay, more biomarkers. So total alkaline phosphatase is very easy. Bone formation rate as bone-specific alkaline phosphatase, bone resorption biomarker, you know, like TRAB5B or CTX. I know I don't want to go over these details, are helpful. If you want to understand the bone formation and bone resorption non-invasively without bone biopsy, you need to add, if you add a panel of tests, not only the BTH, especially if the BTH is not super high or super low, add more biomarker, you will get more precise evaluation of the bone status.
Thank you very much, Professor Amr. Can I ask a question myself? Is it okay?
Thank you, Dr. Elbaz.
Professor Mohsen, please, after your question, we have a question on the chat. Can you manage them after your question?
Yeah, by all means, we can just go for that. I mean, probably you might agree, or you can just correct me if I'm wrong. After all these discoveries and this fascinating physiology and pathophysiology, I feel at some point that we are treating numbers rather than patients. What I mean by that? I mean that, tell me if I am wrong, if we have got up till now any translation into meaningful clinical outcome for the hard endpoint, overall mortality, cardiovascular mortality, renal progression, or even the risk of fracture. After all this treatment of the numbers, I feel that it is an uphill battle treating the CKD MBD. I'm not sure whether we are winning, are we successful, that we are creating, a better outcomes for our patients in terms of hard endpoints. And you can see the level of grading for the KDIGO. It is all of them 2, only one is 1C. So please correct me if I'm wrong.
انت بتقلب الترابيزه علينا، طب نقفلها ونمشي بقى.
No, it is a very fascinating, it's a very fascinating pathophysiology. It is a very complex area. I mean, all what we have got treating the hyperphosphatemia, it is numbers. Are we translating this into reduced mortality, cardiovascular event, reducing the progression of the chronic kidney disease, even the fracture? I'm not sure. Have we got any stronger evidence to say that when we are treating the hyperphosphatemia, we are reducing the risk of fracture in our patients? I'm not sure. You can correct me, obviously, if I'm wrong. I'm sorry. Okay. I'm sorry that I'm asking this question, okay, but you can reassure me. This is what I'm saying.
Yeah. I mean, there is different ways to deal with things, right? First is sometimes we are pessimistic. We can say, yeah, we are treating numbers. There is no evidence that we can improve mortality, survival and decrease mortality and so on. So, yeah, this is, a little bit a negative way of saying things.
I'm really sorry. It might be a negative way. Yes, you are right. You are absolutely right.
That's okay.
But I would like to hear different. I would like to hear different, to be honest.
Right.
Because
but
I might be wrong for what I'm doing.
No, I'm not telling you any different. You know better than me. Your knowledge is much better than my knowledge. But I'm maybe a little bit positive or optimistic, or at least not pessimistic. So no, we are definitely not treating numbers. Okay, and here is the thing. Because when I talk, when we talked about BTH of 4, we are not treating numbers. We have to move away from treating number to treat patient, to be individualized and precise and use more precision medicine and personalized medicine in our approach, right? When we look for the BTH, we don't look to read a BTH number. We don't look to treat hypocalcemia or hyperphosphatemia. We reflect, we think what's going on in the bone, what's going on in the cardiovascular system. All of the time when I teach my student that don't look to this number single-sided. You have to look, it's bidirectional. What is the impact of this? If you see a phosphorus of 7 or 8, what does it mean? Does it mean only that this patient is not compliant with the diet or not compliant with his medication, the phosphate lowering therapies? No, it might be reflecting that this patient have problem with his bone turnover, and this phosphorus, which is about 90% of the phosphorus is stored in the bone, this might reflect bone activity, underlying bone loss that is going, in his skeleton, and this patient is losing bone and the phosphorus is going out. The calcium is mobilizing out. And this is the reason that this patient will have more increased cardiovascular calcification. Waiting for RCTs to solve our problems, they are not going to solve our problem. We know that hyperphosphatemia is bad. We know that, positive calcium balance and calcium load is bad to our patient. We know that our patients are dying because of increased cardiovascular calcification. We know and we see all the time in our dialysis patient how crippled they are, how they end up in wheelchair, or maybe later on they come and go with an ambulance bed, right?
This is all true. This is all true, but our intervention is not translated in something.
If we don't treat these numbers, just give me, let me defend myself a little bit.
No, I'm not saying defend.
Numbers. If you don't treat these numbers, we will end up by having the same catastrophic consequences and the same bad outcomes. What we are dealing, we see on the other spectrum, patient on dialysis for 20, 30 years with good calcium, phosphorus, BTH level, how they live, how you can prevent their fracture, how they live with better quality of life, not particularly because we were good doctors, but whatever, the association between the long-term better control of these numbers that reflects not only number, but also structural activities and turnover and mineralization and bone volume loss and calcification process. So, the thing is, we know that very high BTH, very low BTH, very high phosphorus, very low phosphorus, same with calcium, is associated with definitely with higher mortality, definitely with poor outcome. We need to improve at least the severe form, at least decrease the gap, fill in the gap, put them in the midstream, and instead of, because if you drive either extremely on the right side or extremely on the left side, you might hit the curb. But if you drive in the middle, the chances, perhaps you can arrive safer. So don't be extreme. We just need most of our patients to be modest in the midstream.
Thank you very, very much. I believe that you have been, you are very tired now, but I have got, a couple of questions. It's up to you whether you would like to answer them, or you can just answer them by chatting with them directly.
I will never be tired.
Okay,
while
great.
I'm talking
Great.
with you, Dr.
So,
Mohsen, or with the rest of our participants.
Thank you very much.
So happy you charge my battery and I can stay with you all night. Don't worry about me.
Thank you very much. So someone is asking, what about the aluminum assessment of the serum aluminum level instead of the biopsy? Because the biopsy, you have got the concerns, the biopsy.
That's a good question. That's a good question. Okay, yes, you can do this. We do this. Actually, it's recommended to do it annually. The problem is, again, numbers. Okay, you send it to Al-Ma'amir, right? You send it to do it in lab that they have never examined the aluminum in the water treatment. Of course, you do it in the water treatment, but also you do it in the serum. Do it, doing the aluminum level in the body specimen is not as simple as you do it in the water. Okay, so you have to send it to someone who knows how to do it. If I think, or my proposal, if we order this more often, or if you do it more often in certain lab, or somebody can do PhD thesis or master thesis, or some experts will develop and will build up team that can have a team that can do bone biopsy assessment. Another team can do our lab with the BTH, with FGF, with the aluminum level. Yes, you can do that. If it is high, it's high. Okay, that's bad. The problem is it can be low. It doesn't mean necessarily exclude that the bone aluminum is not high. And this is another big discussion. We can talk about how we diagnose with, actually we do despheroxamine test, because you also mobilize with the despheroxamine the aluminum from bone to the serum, then you do the test, then you see the higher level, but it's a long discussion. But of course, this is important point to.
Thank you very much. So the second,
excuse me, I would like to thank Dr. Muhammad Abdelbari for the last question about aluminum toxicity. For Muhammad Abdelbari, he was the
دكتور محمد شكرا جزيلا. انا يعني ما خدش بالي لان انا بحاول اسرع عشان انا عارف ان الوقت دلوقتي عمال يجري ورانا.
شكرا دكتور محسن، شكرا
جزيلا.
شكرا جدا. محاضره رائعه دكتور عمرو و very fruitful discussion also. Please continue discussion. دكتور احمد حلاوه want to make discussion. دكتور سعيد خميس please be patient with us. شكرا.
دكتور عبد الباري.
شكرا.
So I've got a question here. When you use the calcium supplement and active vitamin D and the Zemplar for more than 6 months, and still the BTH not reaching the targets, the numbers.
It's not going to reach the target.
You will consider the surgery.
Dr. Halawa is with us now. I think he can comment on that, and we talk about this all the time. It's an aggressive surgery. It's an ugly surgery. He is the surgeon who does that, and he is telling me all the time it's an ugly surgery. He doesn't like to do it. But this is our problem. He's just trying to clean our ass, as he said. I'm sorry to say that. I mean, we don't control the severe Hyperthyroid disease, severe Hyperbaria, either because we fail. Either the patient is non-compliant, the healthcare system is not, helping us, or the physician is neglecting. There is, a problem. Then it ends up in the surgeon's hand. And good luck for that. I mean, not everyone is like Dr. Halawa. They don't understand our patients. They don't know our guidelines. They treat this as patient with primary hyperbaria. The worst nightmare for a surgeon is to have a failure of surgery. And failure of surgery for him is to see BTH of 200 or 300, which is very, very rational and good target level for our patient. But they don't, most of the surgeons, they don't understand this language. So before sending them to the parathyroid surgeon or to head and neck surgeon or to whatever kind of endocrine surgeon, talk to them, talk to the surgeon, tell them our target is to keep the BTH more than 150. If you give me a BTH of 4 or 5 or less than 100, it's worse than if you keep the BTH of 600 or 700, okay? Teach him, because they don't, even if you see their literature about successful surgery, they talk about highest level. They never talk about lowest level, but this is not successful surgery if you leave a patient with a BTH of 4. This is completely irrational. It's a disaster. And who is going to deal with this? That's us forever. The patient will be stuck with us with a calcium of 5 or 6, frequent hypocalcemic manifestations and tetany and seizures and admission. Okay, the other thing, and we can again talk about this till tomorrow, you give calcium and you give vitamin D. If you don't have BTH, where does this calcium go? The BTH keep the calcium in the blood. It mobilizes the calcium from the bone. It will increase calcium absorption, reabsorption in the kidney, and it will activate vitamin D to increase calcium absorption in the gut. If you don't have BTH and you give extra or mega doses of calcium, the bone is dead. There is low turnover bone disease. So 99% of the calcium that usually goes to the bone is not going. The patient have end-stage kidney disease, so doesn't excrete this or excess load of calcium in the urine, where the calcium goes, and the calcium stays 6 or 7, and you are giving mega dose of calcium. Think about it, where the calcium goes. I will leave you without an answer. There should be another compartment or a place that takes the calcium. It's very important that probably it's going to induce some harm that we don't know, and this harm may be increased cardiovascular calcification. So be careful. You don't have to correct the calcium. It doesn't have to be normal, but just try to avoid severe hypocalcemia.
Right, thank you very much. I have got another question from Dr. Khalid Abu Zaid. Probably he would be better to, talk himself about the question because it's written here unclear to me. Dr. Khalid Abu Zaid, would you please?
Assalamu alaikum.
Thank
you, Dr. Amr, for this excellent presentation. My question actually as regards the primary hyperparathyroidism, because actually I have one patient for at least 2 years with isotope scan negative isotope, regardless of primary diagnosis as a primary hyperpara and continuing medication. He's non-compliant, sometimes on and off, and this patient is, we cannot detect parathyroid gland by isotope. What's your explanation? Can we find
what is the BTH, Dr. Khalid? I'm sorry.
BTH is 250, but the isotope is negative twice. The gap in between the two studies is about 6 months, and is suppressed by using the medication. But after withdrawal of the medication, the BTH will be increased, and calcium also is high. And
how high is the calcium?
Calcium is about in between 10.5, 10.6 to 11.
Okay, and how old is the patient?
Patient is about 40 years old, and he's English man, and following with us here in Saudi Arabia.
Very good, very good. Did you do a DEXA scan? Does he have any evidence of bone loss?
DEXA scan is negative. There is no bone loss.
There is no
because the patient loss. Actually is actually mainly the patient is diagnosed by that. There is no stones, no groans, psychiatric overtones. The other presentation of primary hyperparathyroidism is not present. Only the patient is incidentally discovered hypercalcemia and high BTH, and there is no other findings. And in treatment on and off.
Urinary calcium is normal?
Urinary calcium is normal.
And just a few more questions if you want just to take a decision about this patient. I'm sorry. GFR is normal?
Yes, he was presented to me by acute kidney injury, but treated by some fluid resuscitation. And after correction of the calcium level and BTH, the renal function returned to the normal.
Last question, the 24-hour urine calcium, is it elevated or normal?
No, it's not elevated at all. It was normal. Always studied at least for 4 times that it was normal.
That's very good. So you don't have to worry about it. Just watch it for now. If there is no evidence of increased urinary calcium excretion, this is probably going to translate to renal and bone safety, because they lose their bone when the filtered load of the calcium is high and they start to lose more calcium in their urine. So if this patient is not losing more calcium, so it's not very harmful to have mild hypercalcemia as long as it's asymptomatic. The bone is healthy, there is no hypercalciuria, there is no kidney stone, the GFR is normal. You can watch him up every 6 months or so with serum calcium. As long as it stays less than 11, you don't have to do anything. It's not, you know, an indication to do anything. If it goes then more than 11, you can try cinacalcet, small dose of cinacalcet that can control his serum calcium concentration. But the bottom line is, as long as the 24-hour urine calcium is normal, no bone loss, no stones, normal GFR, this patient might be tolerant to this mild hyperbara for years and years.
Right.
My stupid question, my last stupid question, معلش يا دكتور. Can we find the ectopic parathyroid somewhere rather than the neck and the retrosternal? May we find
systematic scan. When you send the patient later on, maybe you know, you don't have to do it right now. We just have to be patient because first of all, I talked a little bit about the sensitivity of the systematic scan. It's very variable from radiology department to another. You have to send this patient to you know, a radiologist who know how to do it. And if they don't do good part of the mediastinum and the upper part of the abdomen, so it's not only when you do the systematic scan, you focus on the neck, but they have to also visualize the chest, you know, the lower and upper mediastinum, which are the most common places for the ectopic parathyroid tissue. So focus on this. Maybe later on send the patient to a better lab to give you a better image with the systematic radioisotope.
The discussion will be going and ongoing and ongoing. There are two last questions, and probably we need your lecture, another lecture, definitely. This will not be enough at all.
Dr. Mohsen, Dr. Ahmed Halawa wants to comment.
This is what I'm saying. So the two comments will be Professor Halawa and Professor Saeed Khamis. These are probably the last two, but I have got plenty. If you can just please make sure that you can answer them even by direct chat with them, that would be great. Thank you very much, Professor Am. Professor Ahmed Halawa.
Thank you very much. I was, you know, listening to the very interesting and elegant lecture. I'm not complimentary to anybody because, you know, I don't do this. Number one, yes, you know, this is a comment on Mohsen himself. Yeah, we are looking at numbers. Numbers are important, and this is, we use numbers to screen. So we cannot do bone biopsy for every patient to diagnose the bone disease, CKD, MBD. So we rely on numbers. And this is how you refer patients as well, based on numbers. But, you know,
but I mean, I'm not going to through this discussion. I will just carry on with that because, I mean, the bone biopsy is not available everywhere. The bone biopsy has got very huge limitations. So carry on.
Yeah.
And this is a way of frustration. That's it. This is what I'm saying.
All right. Okay. Yeah. So numbers.
I'll give you numbers as well.
Yeah. The second thing, you know, I totally agree with Professor Elhussieni. I think we got the wrong people on the chat here. We need the surgeons, you know, who work unilaterally without listening to anybody, and they think they are great, and they think they understand the disease. Hey, yeah, I managed to get 4 parathyroid glands, and you leave the patient with 0 PTH. And they don't understand that we are created with PTH. So PTH is important. Without PTH, we cannot have bone remodeling by all means. And they don't understand that, you know, without PTH, the calcium, whatever calcium you will take will be lying in the tissues. So the heart valve and other tissues. So we need to educate and tell them we need PTH of 150 to 400. So education is based on you when you refer this patient. Totally, 100% agree that we should let them know what is right and what's wrong. The most important thing is you need to understand that adynamic bone disease is a disease associated with mortality and increased fracture rate. So they are trading, you know, the profile of the disease from hypoparathyroidism to hypoparathyroidism. So, you know, this is not good at all. The last comment regarding the case presented from Dr. Khalid, Saudi Arabia, I think you rely on systemic scan to confirm your diagnosis. Exactly like what Professor Am said, you cannot rely on radiology to confirm diagnosis. You have PTH, high PTH. So definitely this is hyperparathyroidism. Professor Amr investigated thoroughly, the other parameters, urinary calcium secretions and all other things, but he has high hypercalcemia. So high PTH 250 and hypercalcemia, this is enough to diagnose primary hyperparathyroidism, and especially he's not a CKD patient. In terms of, I disagree with Dr. Khalid. He said, there is no psychomotor disorders. Actually, this one will be discovered in retrospect. When this patient get the parathyroid, usually 1 or 2, removed and PTH normalized, he will tell you, no, I think I was mad. I was not right. I didn't realize I was not in a right mental state. Always discover in retrospect when they have the high PTH and high calcium treated unsorted. So it's difficult because if you ask them, do you have any problem? Do you have? No, I'm fine. But when you operate on him, look, I feel better. I think I was depressed. And this is actually, I question all these patients who had successful
I'm not sure from where this is coming. Carry on.
Had successful, parathyroidectomy. They can tell the difference. I think this patient needs surgery. Systemic scan is not always sensitive, is not always specific. Number one. Number two, if you have a multi-gland disease, which happens in 10 to 15% of primary hyperparathyroidism, the systemic scan will be associated with less sensitivity. It's good sensitivity up to 90% and higher in single gland disease, but in multi-gland disease, it loses its sensitivity. And this is one of the problems, the nephrologists investigate high PTH and send, request a systemic scan. Systemic scan in CKD patient will discover lower right parathyroid, send it to the surgeon. The surgeon will jump into the neck and remove the lower right. That, yeah, I've done what's already in the scan. They don't understand as well, it's a multi-gland disease. You need to look for the 4. And so, you'll be stuck between the devil and the deep water, basically, either, inadequate surgery or aggressive and radical surgery. You don't need this. You need to sit in the middle. And we'll be lucky if you manage to get the level of 150 to 400, because this is an awful operation. You remove most of the glands and you leave tiny bit, in assumption that this will restore the normal function. You don't know what you have left behind. Is it a piece of fibrous tissue, calcified tissues, area of hemorrhage and necrosis, or glandular tissue? And this is the problem with the surgery. So the most important thing, which is, I think, it was not mentioned, is educating the clinicians to prevent the disease. We don't need to, to be debating whether the parathyroid or to be removed, or the, adynamic bone disease or hyperparathyroidism. If we prevent the disease when the patient reaches CKD3, we can avoid all this. But the problem, these patients always land in the hand of inexperienced or junior or whoever, usually a general physician, and then be referred later on when things get worse, out of control, to the specialist, which is not right. So prevention. But this is not happening. In many parts, in Egypt, when you ask about vitamin D, it's not there. How on earth you manage CKD MBD without having vitamin D level checked? So these are the comments, basically. regarding the the patient from Saudi, excuse me, Dr. Am, I disagree with you. He needs a surgery.
Right. Okay. Probably we can leave this debate because there is a plenty of questions, but we will have only one other one from Professor Khamis, and then
please, Dr. Mohsen, just one more comment for this patient. Me and Dr. Khaled and Dr. Hawa can talk offline about this.
Sure.
Yeah, by all means. And you have got plenty of questions. Please, if you don't mind, don't forget them and answer them individually or personally, if you don't mind, on the chat.
Mohsen, yeah, we are happy to to carry on discussion.
I'm more than happy. I mean, if
fine. Yeah. Don't worry about us.
Okay, that's fine. Carry on. Professor Amr, are you happy to carry on?
I'm always happy with you, sir.
Okay, that's fine. So Professor Saeed, and then we can just go ahead with the rest of them.
Saeed is Professor Saeed, please.
Good evening, Professor Amr, Professor Mohsen, Professor Halawa, Professor Yasser, and Professor Tariq, and Professor Faisal, all professors. Thank you for this amazing presentation, as usual, Professor Amr. I'm sorry, and I joined it a bit late, but anyway, I have one question, if you don't mind. What is the relation between the iron therapy for anemia of CKD patient and the CKD parameters, especially with the recently raised what's called 6H syndrome? This is the high FGF23, hypophosphatemia, hyperphosphaturia, and hypovitaminosis D, and hypercalcemia, and secondary hyperparathyroidism, seen with various IV iron formulations, but most prominent with ferric carboxy maltose. It's to occur as a result of impaired cleavage or inactivation of the phosphatenins FGF23. What I mean, iatrogenically, regarding the iron therapy, can be a culprit in CKD MPD progression. And thank you so much.
Probably you know the answer better than me, Dr. Said. Thank you for this question. Yes, I came across this study when actually non-CKD patients, when they receive mega doses of ferric carboxy maltose, what happened is there is several case reports and small studies. It induced hypophosphatemia. This is very well known for almost a decade now, but what happened is more recent study, they found that FGF23 goes high because it impairs the cleavage. There will be more biologically active FGF23 that can induce a phosphaturia. So the second thing is what will happen in CKD. Could it be good that you give this carboxy maltose to decrease the serum phosphorus on the expense of the FGF23? It's very hard to do this because actually in end-stage kidney disease patient, if they don't make enough urine, if their residual kidney function is very low, the hypophosphatemic effect of this ferric carboxy maltose is not going to be there, right? Because the patient is not making urine, there is no phosphaturic effect. But what will happen is you increase the FGF23 levels. It will be more biologically active. Can it induce more cardiovascular problem, left ventricular hypertrophy, increased calcification? This is just a hypothesis because you don't give this ferric carboxy maltose forever, and it's actually not very well studied because it hasn't been there, I think, for several decades. It's just a new treatment. I don't know even if it is available in Egypt. Of course, if you activate the FGF23, you will anticipate that the active form of vitamin D will go down. Hypocalcemia can happen. Actually, the BTH, it can induce low or adynamic bone disease because the BTH might be suppressed. So these are all interrelated. However, we don't have long-term follow-up study giving this carboxy maltose and evaluating what exactly happened with different stage of CKD and in patient with residual versus non-residual kidney function. But thank you so much for bringing this up. Yes, IV iron therapy, especially the ferric carboxy maltose, can be a player of this, especially in early CKD. You have to be careful. It can induce hypophosphatemia. Hypophosphatemia can induce osteomalacia, can induce low turnover bone disease. So we have to be careful. In end-stage kidney disease patient, the story is different here, but we have to be vigilant. Thank you, Dr. Said.
Thank you, Professor Amr. Thank you, Professor Said. So another question, how can urinary calcium quantification differentiate between primary hyperparathyroidism from familial hypocalciolic hypercalcemia in a case of hypercalcemia with normal parathyroid imaging?
Thank you so much for this question. It's a very good question. Okay, so in patient with primary hyperbara, my question is, are they hypercalciuric or not? You know that FHF, they are hypocalciuric, right? No doubt about that. The 24-hour urinary calcium as a distinguished or diagnostic, parameter, the urinary calcium should be less than 100 milligrams per day, right? Okay, let's talk about the hyperpara. What will happen? Hyperpara, we anticipate that the BTH will try to return the calcium, will try to reserve and reabsorb more calcium. But the truth is, in patient with primary hyperpara, what will happen is they are hypercalciuric. This is the reason that hypercalciuria is one of the most important risk factors for stone formation, for the nephrocalcinosis. The FHH is usually asymptomatic, doesn't need treatment. Why? This is because they are not hypercalciuric, they are actually hypocalciuric. So they don't form stone, they don't have lower GFR, they don't have higher urinary calcium, they don't lose calcium in the bone, so there is no consequences in their bone, so the bone will be maintained, they don't lose bone, okay? So this is the reason that we don't treat FHH. It's asymptomatic, it's just we need to get the right diagnosis to avoid treating it or mistreating or misdiagnose it as primary hyperbara. Why primary hyperbara are hypercalciuric? Because, and the answer is just one answer, and I usually ask this to my students, because the filtered load of calcium is high, okay? What does this mean? And I'm a little bit peculiar about that. Do you see my screen? Dr. Mohsen, do you see my screen?
Yes, I can see your screen,
okay.
Yes.
I can explain to you this in very quick. Here is the kidney, right? Okay, in normal circumstances, there is 200 milligrams of calcium goes to the renal circulation, right? Sorry for my bad drawing. The kidney will excrete about 180 milligrams of that. So 90%, right, will be excreted in the kidney. And 20 milligrams will be reabsorbed in the blood. In cases of hyperbara, the primary hyperbara, the filtered load will be doubled. Say, will be, instead of 200, will be 400. The kidney will try to reabsorb more. There's no doubt about that. BTH is there. They'll try to conserve more calcium. So instead of reabsorbing the 10%, it will reabsorb, say, 20%. What's 20% out of 400? This is 80, right? The 20%. So this is 10%, right? It will reabsorb 20 in normal circumstances, normal environment, apart from 200. So that's 10%. Here, it will reabsorb, say, 20%, right? So still, there is increased reabsorption. But what will happen here? The excretion will be 320, right? So they are still hypercalciuric. Despite that, they reabsorb more calcium. So here is the paradox. Because the filtered calcium load is higher, the N is higher. So despite you are reabsorbing more, but you will end up by having hypercalciuria in cases of primary hyperbara, and hopefully everybody can understand this concept.
Right. So probably there is another question. Let me see, what are the best diagnostic method for assessing the osteoporosis or the bone density in the patient on hemodialysis?
So it needs another lecture. Okay, it's
think
not
we
the
will
best.
have
The most
You
widely
said that
available.
you are okay. I said that it's more than
I'm
enough.
okay. I'm okay. If you give me time, I can go on.
I think
So,
yes, Professor Yasser. Yes, Professor Yasser.
try to explain shortly, Professor Amr, as we will have a separate session for this, and we will not find any more information. We will say all the information in the discussion.
Right. So yeah, DEXA scan is very helpful tool. It's very easy to do. It's very cheap. Radiation exposure is minimal. You know, it's available everywhere. You can do it. Of course, there is tricks. If you do, you know, the DEXA scan for CKD patients, it's a little bit different. You have to understand some concepts here. It doesn't differentiate trabecular from cortical bone, right? And in patients, especially with high turnover bone disease, they have what we call it cancellization or trabeculization of their cortical bone. The problem starts mainly in the cortical bone. By the way, DEXA scan is not only don't distinguish between cortical and trabecular bone, but also it's mainly a trabecular bone assessment, okay? Especially when you do it on the flat bone, especially on the spine. It doesn't, the spine is, you know, 99% cancellous bone, not cortical bone. Anyway, so again, in patient with CKD, it gives you false higher readings, especially in the spine, because increased cardiovascular calcification, because of osteophytes, because of you know, or not only the osteoporosis, but they have also some osteolytic lesions between in the intervertebral disc space. Anyway, so it gives you false higher reading, especially in the spine. So you have to be careful. Cardiovascular calcification, one of the most, because the cursor, once you put the cursor on the vertebrae or in the hip, if you have increased cardiovascular calcification in the aorta or in the major blood vessel, it can, this is calcification, it gives you the same signal as its bone. So it can falsely increase the BMD. If you want to be more, and if you're doing this, do other two things with the DEXA scan briefly. Do what we call TBS, trabecular bone scoring, because the concept is BMD by DEXA is only quantitative, not a qualitative measure. It quantitates the percentage of calcium per area, and it's two-dimensional, not three-dimensional. It doesn't give you the volume. It gives you by a square centimeter, not by cubic millimeter, which is a volume. So it's a little bit tricky. We can talk about this. There's a lot of details about it, but do TBS to add to the quantitative method a qualitative dimension, okay? The TBS, the trabecular bone score, is underutilized in CKD patient. So please, if you're ordering DEXA scan for CKD patient, ask the radiologist to do what we call trabecular bone score. Okay, they give you a scoring for the bone microarchitecture, which is a qualitative rather than quantitative measure. Last thing, put the patient on the lateral position, do what we call vertebral fracture assessment, VFA. This VFA, in majority of our dialysis patients, they can have asymptomatic vertebral fractures. It can present by no symptoms or non-specific back pains, shortening of the patient height. And we know, and most of our patients, they lose height, they have compression fracture of one or more of their vertebrae. So when you do the DEXA scan, you don't have to do another image, just put the patient on a lateral, give a lateral film, they give VFA, they can diagnose vertebral fracture. So you can give many more values from the DEXA scan because it's very popular and cheap. But you know, again, it's only one tool. There's another lecture to talk about other non-invasive and invasive measurement of and evaluation of bone health and osteoporosis in CKD patients.
Thank you very much. When do you?
This is the reason, by the way, I don't know if Dr. Halawa will agree to announce this, that we are actually working on creating and establishing, you know, structural training, organized training, because we cannot cover all of these subjects in a webinar or in a lecture. We have to have structural training, and I'm learning from Dr. Halawa and he is helping me with Dr. Elbaz and Dr. Mohsen and other pioneers in the field to establish this training for our nephrologists.
The next question, when do you consider the bisphosphonate in dialysis patients?
Okay, again, very big question. If you ask me this question 10 years ago, I would say we don't give bisphosphonates to dialysis patients. Basically, it accumulates in the bone. It kills the bone for many, many years. You know, science has changed, and now we use it, but use it with precaution. First of all, make sure that exclude adynamic bone disease. So don't treat any patient with osteoporosis blindly with anti-osteoporotic agent, anti-resorptive therapy like bisphosphonates. You have to make sure that the patient have high turnover bone disease. Whatever, I'm not going to talk about bone biopsies and diagnostics, whatever the tool or whatever you are convenient with or you feel comfort with, make sure that the patient doesn't have low turnover. So you are treating bisphosphonates for CKD patients with high turnover bone disease. Don't give mega doses, give modified dose, half dose, maybe increase interval, and do assessment. Don't give, because you give it for years. You're not going to give bisphosphonate for a week or a month. You give it at least for a year or two. Then you do DEXA scan, make sure that the bone is not, your patient bone is not going to be, go down quickly. At least do biomarkers to see that the bone formation rate is not very low, or the bone resorption is okay, because as we mentioned, we need some bone formation, we need some bone resorption. So yeah, there is precaution. Don't give it blindly and let the patient to take it for years and years, then end up by it having a typical bone fracture or losing bone. You have to make sure you're doing the right thing.
Dr. Professor Faisal Shaheen wants to comment, Dr. Mohsen.
Okay. So, thank you.
Well, I enjoyed the talk very much and the discussions also. Amr, you are amazing. Every time you bring to us a new things and how to make a good presentation about bone disease in CKD patients and robust physiology. Really, I enjoyed the talk and I enjoyed the discussion, and nothing to be added, but probably I missed about the, parathyroidectomy. Either we lift one gland in, or as before we were doing to take one gland implanted somewhere else. There is any study to compare the implantation of a gland in the hand or to leave the gland inside during parathyroidectomy?
Thank you so much, Dr. Faisal. It's always an honor to have you in this meeting, and you always add to our knowledge. Thank you so much. I will let Dr. Halawa to comment on the surgical intervention if he wants to. Dr. Halawa, you're muted.
Thank you, Professor Faisal, for this question. Actually, the studies, there's no structured, well-designed studies comparing total parathyroidectomy with auto-transplantation with subtotal parathyroidectomy. The only outcome which could be sensible is they think the beta control of hyperparathyroidism by total parathyroidectomy and auto-transplantation. However, there is high incidence of adynamic bone disease and hypoparathyroidism with this operation. And also, from my practical experience, I moved from auto-transplantation, because you don't know what you auto-transplanting. It could be transplanting a piece of calcified dead tissue, no glandular tissues at all. So we'll end up by hypoparathyroidism with PTH 0, 1, 2, and definitely adynamic bone disease. To subtotal, where you leave a tiny bit of apparently normal gland with intact pedicle. This actually more physiological. There is less interruption of the vascularity of the bit of the gland left behind. And actually it helps as well in the post-operative period where, if you auto-transplanted piece of parathyroid tissues, the patient will be hypocalcemic and subsequently suffer from hungry bone syndrome. So post-operatively, the situation is more stormy compared to the subtotal, where you have still PTH. The calcium won't be, won't go foot low. The calcium will be reasonable, and patient can be managed sensibly in the post-operative period. So my impression is, my experience, which is, in terms of evidence, this is level 5 evidence. Subtotal parathyroidectomy is more physiological.
Thank you very much.
And thank you, Dr. Halawa, for this explanation. Amazing as usual. I want to add something very quick. We studied this, even in our patient in Kentucky, in 87 patients who had parathyroidectomy because of either intractable secondary or tertiary hyperparathyroidism. 31%, or almost 1/3 of them, they have to be readmitted to the hospital within 3 months for treatment of hypocalcemia. Okay. The other thing, 80% of them, they had BTH of less than 150. So by all standards, they have lower, BTH level, 80%. Actually, about 75 of them have BTH of less than 100. So there is another study that was done in Brazil, this one. So see this study, small study, but they did bone histomorphometry analysis before and after parathyroidectomy, 1 year after, okay? All of the patients, of course, they have high turnover bone disease prior, 19 patients. What happened after 1 year of follow-up? As you see here, 80% have very low bone turnover. 90% have low turnover. If you add this 10% to 80%, they are 90% low turnover, 80% very low bone turnover. What they also found that patients who end up by having low turnover bone disease, they have more cardiovascular calcification. So they did a multi-slice CT scan on their heart, cardiac CT, and patient with lower BTH, patient with lower bone turnover, they calcified more their blood vessel. It's alarming sign. We don't have such longitudinal perspective for our study that evaluated the bone health and the cardiovascular health after having parathyroidectomy for end-stage kidney disease is one of few studies that has done that. So we have to be careful. It's not a magic. And as Dr. Hara always saying, it's terrible surgery. It's an awful surgery. And the surgeon have to understand, as Dr. Howe said, the consequences of having low turnover bone disease. As usually the problem with high turnover bone disease, it's very well spoken. It's a loud, disease. You feel it, you hear it, and the patient will complain out of it. Even the radiological finding would be very obvious. But low turnover bone disease is a silent killer. Is a quiet, is asymptomatic at the beginning, and there is no such things going on in the bone. The patient with loose bone will have more cardiovascular calcification and will die in peace, as they said, without making noise. So we need to avoid this. Again, whatever subtotal, total, auto, transplantation in the arm or in the deltoid or in somewhere else, we have to leave the patient with parathyroid tissue.
Yeah, but
please, we close. I have a question, Dr. Am.
Yeah,
Dr. Halawa has a comment, I think.
Just a small comment. Were you comparing between subtotal parathyroidectomy and total parathyroidectomy with autotransplantation, or my understanding, based on the slides, you're comparing between operation and no operation? Am I right?
Right. Yeah, I have. If you allow me, if you have more time, I can show you several other
because actually
studies.
I'm more interested in this.
Yeah, without autotransplantation, with total and autotransplantation, both ends with low level, both ends with the same consequences. But again, you know this better than me.
No, I don't know anything.
Professor Yasser, do you have a question you're saying?
Yes, before we close, excuse me for the last question. Professor Amr, you said that in the view of hypercalcemia, moderate and severe PTH above 20 is considered hyperparathyroidism. What about the mild hypercalcemia? Does it keep the same sensitivity or behaves in a different way?
Yeah, that's a very good question. Thank you again, Dr. Yasser. So we have to think, what is the stimulus for BTH secretion is the low extraserum calcium concentration. So, you know, the main stimulus, the main controller, the main regulator of BTH is the serum calcium. So there is, and I showed the figure, how it, you know, correlates very nicely and tightly, the very intimate, you know, relationship between serum calcium and BTH. So if you have elevated calcium, BTH should be suppressed right away. How much? We can go again to the curve and see physiologically how you would anticipate, you know, with mild elevation of the calcium level. Usually, even if you go 0.1, which is equal to 0.1 millimole, which is equal to 0.4 of milligram, which is almost close to half of milligram per deciliter, down, there is 50% reduction. If you go up in the calcium, there's 50% reduction of the BTH. So if the BTH initially was 40, if you increase the calcium from 10.0 to 10.4, this should be inhibited to 20 again. So there is, we can go over the curve again if you have time for that. But the basic knowledge is there is very intimate relationship. Any mild increase, any trivial or marginal increase in the serum calcium is usually associated with suppression of the BTH and vice versa.
Okay, yes, it seems like it behaves in the same way, even in mild hypercalcemia.
Right, and the curve, of course, with severe cases, it goes, the suppression will be severe, and you can go back to the curve and see how the relationship, but yeah, there is intimate, very intimate relationship.
Thank you.
Dr. Halawa sees this all the time. If you remove the BTH during the surgery, if you don't give, and this patient again have high turnover bone disease and Hungary bone syndrome, if you don't give calcium, if you give vitamin D before the surgery, the serum calcium goes, you know, dramatically down, and the patient can have a seizure in the OR.
I believe that I am the one who is listening. I am got tired now, and for yourself probably. I'm not sure. There are some few questions about the vitamin D active and inactive, and I would like to stop here just only for one reason, to have the second lecture, so we can have this amazing discussion and having this amazing teaching. And please don't deny us this chance. What do you think,
Absolutely, Dr.
Yes,
Mohsen, you know that I'll get inspired. When I started the lecture, I was tired, I was pale. Now I'm, you know, red and excited and healthier.
Yes,
so please don't stop me from having this opportunity. I get healthier, you know.
Can take 1 hour rest.
Dr. Farah, I want to say something, you're muted.
بس يا دكتور عمرو كده الغده هتطلع لنا في النوم يعني ننام يعني انا كده قدامي الغدد لازقه في الثيرويد. احنا قربنا الناس.
مش كده برضه، مش كده حضرتك برضه، انا بقول كده.
يا جماعه انتوا شباب يا جماعه، ايه الحكايه؟
بس انا حماسي بس على الدكتور احمد حلاوه، وحشنا بقالنا كتير ما شفناهوش، نتعشى نشوفه قريب. بس اي ثينك يعني 2.5 ساعة و5 دقائق.
يس وي ار تو كلوز.
مش كده برضه يعني، لا عشان كمان يبقى التشانس ان احنا ناخد الليكتشر الثانيه بمشيئه الرحمن، لان كده مش عايزين اكزهوست all the questions tonight.
سيكي دي ام بي دي ده ما بيخلص
بالظبط كده يعني. ده قصه very fascinating very complex needs some dissection.
انا اتعشى ان احنا نسمع بقى الفيتوين والسكليروستينز ويعني الفاسكولار كلاسيفيكيشن. طبعا الاستاذ الدكتور طارق الباز اكيد هيغطي النقطه دي الاسبوع الجاي.
was some promising hard end point. I mean giving us some sort of opportunity to feel happy.
Thank you.
Thank you very much.
سعيدة ليكم كلكم ان شاء الله.
Thank you Dr. Mohsen for moderating this very interesting meeting. Thank
أنا
you.
اللي متشكرين جدا والله، أنا متشكرين جدا.
Thank you Dr. Amr for very interesting, comprehensive and very nice lecture, and for responding to us and tolerating us for all through this period, about approaching more than 2.5 hours. Thank you all professors who shared and who enriched the discussion with their very rich experience, and for all audiences who shared us and are joining us till late night. excuse me, to close this session, and we will have next week. There will be no session as there will Transplantation Chapter Congress, and we resume our usual schedule in the start of July, inshallah, and will be announced later on. Thank you. تصبحوا على خير.
شكرا جزيلا. شكرا جزيلا.
السلام عليكم ورحمة الله.
تصبحوا على خير دايما.
Thank you so much.